Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! RSNA is now accepting abstract submissions for RSNA 2021. Submit your abstract and deliver fresh insights about important topics while you shape educational programming at the annual meeting. To get more information and share your work, go to rsna.org/abstracts. Submissions are due no later than 12 noon Central Time on Wednesday, May 5th. Hi, listeners. On today's episode, we discuss a recently published original science paper from the journal. The paper is titled Specific Ventilation in Severe Asthma Evaluated with Non-Contrast Tidal Breathing Proton MRI. This work comes to us from our colleagues in the United States and Canada. The lead author is Dr. Dante Capaldi, and the senior author is Dr. Sarah Svenningsen. So, from the title of the paper alone, you can see that a unique feature of this investigation is the use of proton MRI rather than hyperpolarized gas MR or ventilation SPECT in understanding respiration. This study was a single-center observational study. The investigators recruited 27 patients with severe asthma, as well as 7 healthy controls. These patients underwent inflammatory marker lab testing, spirometry, and tidal breathing proton MRI. From those proton MR data, a unique biomarker called specific ventilation was calculated. The investigators aimed to determine if MR-derived specific ventilation was responsive to bronchodilators and if that specific ventilation was associated with biomarkers of airway inflammation. Regarding the results, MR-derived specific ventilation was indeed significantly improved with bronchodilators in patients with asthma. On a more granular level, this bronchodilator response was greater in patients with lower inflammatory biomarkers compared to those with higher inflammation. To discuss the study design and results further, I had the pleasure of chatting with the lead and senior authors. Let's jump into that conversation now. Welcome back, listeners. I am now joined by the senior authors of our featured paper, Dr. Dante Capaldi and Dr. Sarah Svenningsen. Dante and Sarah, thank you very much for coming on board.
Thank you very much for having us.
Yes, thank you.
Of course. Before we dive into the featured paper itself, let's learn a bit more about each of you. Could you talk about your current role, where you work, and what your current academic areas of interest are? Sarah, why don't we start with you?
Absolutely. So my name is Sarah Svenningsen, and I'm a PhD scientist and Canada Research Chair in Translational Pulmonary Imaging. I'm an assistant professor of medicine at McMaster University, which is in Hamilton, Canada. And my research program at McMaster primarily focuses on the development and clinical application of novel pulmonary CT and MRI measurements to better understand, evaluate, and manage complex airways diseases such as asthma and COPD. And I would say that most of my research to date has focused on the direct assessment of ventilation in patients with asthma using hyperpolarized gas MRI.
Awesome. That's going to lead well into the discussion of our paper and the topics at hand. But before we get into that, Dante, why don't you introduce yourself as well?
Yeah, so my name is Dante Capaldi. I'm a board-certified medical physicist and assistant professor in the Department of Radiation Oncology here at the University of California, San Francisco. My primary role and duties are within the clinic, specifically in the radiosurgery department. And I'm also involved in the education program here as the associate director of the medical physics residency program. But aside from that, I did my work back in Canada with Sarah as a graduate student, and I'm still very engaged and interested in lung imaging. And even here, I've had opportunity to collaborate with our radiology department on even exploring some of the low field MRI applications, in addition to continuing my great collaboration with Sarah.
Fantastic. A lot of hot topics that we can get into during our conversation. want to start by asking what inspired this work, this recently published work on proton MR ventilation imaging in our population of patients with asthma.
Really over the past decade, there's been an increased interest in the use of ventilation imaging to improve the clinical management of asthma. And really, most of this interest, I would say, has been drawn from hyperpolarized gas MRI, which obviously requires an inhaled contrast agent, specialized hardware, and also regulatory approvals, which are now in place in the United States. But because of those requirements, which can be considered complex, the clinical implementation presents some challenges, which we think can be potentially mitigated proton-based ventilation imaging. And Dante has done a lot of seminal work with non-contrast tidal breathing proton MRI based methods to assess ventilation, and that really set the stage for this publication. So I can flip it over to him, and hopefully he can speak to that in a little bit more detail.
Yeah, Dante, let's hear from you. And if you wouldn't mind, in addition to talking about what Sarah was just discussing, discuss some of the differences between proton ventilation imaging versus what others may be familiar with, for example, xenon SPECT or hyperpolarized gas MR.
Yeah, to Sarah's point, we've previously explored proton MRI, specifically in asthma in the past, and comparing against noble gas MRI. And to your point, the main difference really is that for these other imaging techniques, it requires contrast agent or inhaled contrast agent, which is a real direct measurement of pulmonary ventilation. Where these approaches, they're non-contrast enhanced, so there's no exogenous contrast needed. They're free breathing, and they're also indirect measurements of pulmonary ventilation. And the beauty behind these methods is that they can be acquired on any currently available scanners. So with all that information, we wanted to further explore proton MRI, specifically in patients with asthma. And in the past, we did comparisons between noble gas MRI and proton MRI. But we really wanted in this study in particular, really to do a deep dive and trying to just better understand the relationship with these ventilation metrics we were extracting from imaging and compare them to known components of airways disease, specifically smooth muscle dysfunction, as well as airways inflammation. And we did this by evaluating asthmatics with the use of bronchodilation or bronchodilator therapy and looked at relationships with type 2 inflammation and airways dysfunction.
Perfect. Dante, there's a lot to unpackage there in terms of what specific metrics you were evaluating in the study that's published recently. So let's start by talking about the ventilation metrics, in particular, specific ventilation. Some in our audience may not be familiar with this term. Could you help us sort of define what specific ventilation is and how this was evaluated on proton MR?
Yeah, absolutely. The specific ventilation metric that we're extracting in this study and we're investigating is a measurement of signal intensity differences of this non-contrast enhanced proton MRI acquisition, looking at the difference from inspiratory and expiratory lung volumes, and then normalizing it by the signal intensity at the expiratory lung volume. And we thought to look at this as a metric, as in the past, we validated against contrast enhanced methods. But this indirect measurement itself, fundamentally, you can think of it as the expansion and contraction of the lung. And we're measuring the voxel intensity as the density within that voxel changes through the respiratory cycle. So that's the measurement fundamentally. And for voxels that don't change from inspiratory to expiratory, we kind of assume those to be ventilation defects. But those that do change, and that magnitude in change, as I was describing through the way we quantify it, is the measurement we're extracting here, which is the specific ventilation or the fraction of ventilation.
Dante and Sarah, I have a set of follow-up questions for you about that. Dante, first off, how big is this difference between signal intensity in inspiratory and expiratory images? Is it a substantial difference that's quantifiable, or can it even be qualitatively assessed? And Sarah, if you wouldn't mind talking about some of the data that supports the use of this type of technique for evaluating ventilation in MR in general or specific to proton MR.
So kind of what we've even said in the paper and what others have looked at, The relative change is effectively what the specific ventilation measurement is showing, which is effectively around 5 to 20% signal intensity change between inspiration and expiration. And the absolute value just in signal intensity is around 3 to 10 SI units. So that's what we're measuring globally with the whole lung at those two different lung volumes.
And Sarah, would you mind commenting on how this has been validated in the past on general MR or specific to proton MR?
Yeah, I think it's important to emphasize really that the concept of proton MRI to evaluate ventilation isn't new. It's been almost 2 decades since the first time it was described in the literature around 2006. And since then, there's really been numerous ways that have been developed and studied to extract pulmonary ventilation as well as perfusion using free breathing proton MRI. So, for a decomposition based methods, also phase resolved functional lung imaging or pre-full. And many of these methods have been validated using contrast enhanced approaches, such as Dante hit on with, noble gas MRI, and have been studied across a variety of different patient populations beyond asthma, which we focused on. And again, Dante's done a lot of that, seminal work that kind of was a sanity check for us because this is a little bit of a different way to assess ventilation. We first wanted to understand if these methods were giving us comparable information to more direct assessments of ventilation and ventilation abnormalities provided by xenon and helium.
Perfect. That leads nicely into what I suspect many in our audience are going to be asking at this point is, what types of pictures are these? Many in our audience are clinical imagers. So are the images that are generated from this sort of ventilation-based proton MR technique interpretable by the human, or does it need post-processing? And if so, are we looking at just quantitative data, or are there qualitative components to the image interpretation?
There's certainly a lot of post processing, and Dante can speak to that. But maybe I'll just comment first on the qualitative versus quantitative nature of the data that we get. So currently, and in this paper, we've interpreted the specific ventilation abnormalities both qualitatively and quantitatively. So qualitatively, there are certainly visually obvious focal areas of low specific ventilation that can be observed in these images. And in our publication, we showed a few cases, where you could see a visually obvious region or focal region that had low specific ventilation, and that region was improved or there was an increase in specific ventilation following the administration of a bronchodilator. So that's what you would expect in a patient with asthma. There may be a focal airflow airway obstruction. And if we bronchodilate the airway and open up that region, we would expect the specific ventilation to increase. So we were able to identify focal regions in the lung visually. But then when we wanted to quantify the images, we did distill that information down to a single metric, this specific ventilation metric that essentially was representative of the whole lung. So it was a mean value across all voxels. And using that quantitative output, what we were able to observe was that the whole lung measurement of specific ventilation was significantly lower in patients with asthma, and that it was improved after bronchodilation or increased after bronchodilation. So we were able to have quantitative data that supported our qualitative observations.
That's great. And as you had mentioned, and if my understanding is correct, the quantitative component is synthesized into a single metric or a single quantitative value for the whole lung data set. But there is, to some capacity, regionality to asthma, regionality to any small airways disease. Can you speak to if there are ways in which the regional components of specific ventilation can be evaluated?
Yeah, so that's absolutely correct. In this publication, our quantitative analysis did distill the regional voxel by voxel measurements down to a single whole lung measurement of specific ventilation. And this is certainly a limitation as we weren't capturing that regional information in our quantitative outcome. And as you alluded to, using hyperpolarized gas MRI and other methods, there's extensive literature to support that the disease pathology can be quite heterogeneous within the lung. So we're actively exploring the use of, lobar or segmental segmentation approaches to try to provide a more anatomical or regional quantification aspect to this work. And ultimately, I really do think we need to be able to, pinpoint the cause of these functional abnormalities on a regional level, which certainly are heterogeneous in the asthmatic lung. And to get us to this point or to that point, we really need to start co-registering this functional information with our CT data that allow us to relate, regions of low specific ventilation to structural abnormalities that we can see in the airway with CT, such as mucus occlusions, which are quite relevant in asthma.
Yeah, that was excellent. Thus far, our discussion has revolved a lot around the imaging diagnostic component for these patients, but I know that in this particular study, you collected more than just imaging diagnostic information, particularly that about inflammatory biomarkers. Y'all use the term T2 inflammatory biomarkers in the paper, and while some of us are familiar with that, I want to help define what that means. What is a T2 biomarker, and how is it different from the traditional thinking of an inflammatory biomarker?
So type 2 or T2 inflammation is obviously, a specific immune response. And this inflammatory pathway is quite common in patients with severe asthma, such that people with asthma are often classified as having T2 high or T2 low inflammation. And this information is used to guide treatment decisions. So we thought it would be quite important in this study because we were trying to understand, the contributors to this signal that we're capturing with proton MRI to measure these common clinical biomarkers. So there were 4 biomarkers of T2 inflammation that we measured. And again, these are well established in the clinical space of asthma management. So we measured peripheral blood eosinophils, so the blood eosinophil count, to more directly assess eosinophils within the airway. We had all study participants perform a sputum induction. So then we could quantify the actual eosinophil percentage within sputum. And we also were able to assess the presence of eosinophil-free granules, which is a marker of activated eosinophils. And then the 4th measure was the fraction of nitric oxide that can be measured in exhaled breaths. And ultimately, what we did with these 4 biomarkers is we used established thresholds that are used clinically again to generate a cumulative score or a cumulative T2 biomarker score. And this is very easy to understand in that it's just a sum of the number of those biomarkers that were elevated. So a cumulative biomarker score of 0 indicates that none of the biomarkers were elevated and that this patient likely had T2 low asthma. And on the other end of this spectrum was a score of 4, indicating that all of those biomarkers were elevated, indicating T2 high asthma.
Excellent. And you've already described some of the results of the study thus far in the imaging perspective, in that specific ventilation improved in our patients with asthma following bronchodilator response. Let's bring in these ideas behind type 2 inflammatory biomarkers now. So, how did specific ventilation compare to these T2 inflammatory biomarkers, particularly those that have the T2 low or T2 high asthma phenotypes, if you will?
Right. So we made 2 key observations in our evaluation of the relationship with biomarkers of T2 inflammation. The first was that participants with asthma with biomarkers suggestive of T2 low asthma had a greater post-bronchodilator improvement in MRI specific ventilation as compared to those with a T2 high phenotype. And the second observation was that specific ventilation measured post-bronchodilator in those participants with a T2 low phenotype was higher and more similar to our healthy control population as compared to participants with a T2 high phenotype. And if we, consider these results in the context of the underlying pathophysiology of asthma, they really do make a lot of sense and are consistent with the notion that ventilation can be normalized following bronchodilator therapy in patients with asthma whose inflammation is controlled at the time of imaging.
Awesome. With that in mind, is this type of imaging ready for clinical prime time? Can we start to see it out in the community, or is there more that's needed before we get it out there?
So as of right now, no, it's not ready just yet. We do see a lot of great promise with all this studies that we've been involved in trying to investigate this tool and really dig deep down into fundamentally what are the defects we're seeing and how they change with, let's say, bronchotherapy or bronchodilator therapy. But more work is certainly required, such as, looking at the intra-subject variability, both in the healthy patients or the healthy volunteers, and then the patients with asthma, to really just understand the, scan, rescan, reproducibility. We also want to understand and maybe even establish the limits of normal for specific ventilation and the effects of things like age on those limits. So, yeah, not only are we working towards that to get to that clinical implementation, but there's also parallel efforts to work with our clinical colleagues, such as yourself, both radiologists and respirologists, to facilitate this translation to the clinical practice and really identifying those key clinical utility of the imaging to help, ultimately better assess the patients that we're all seeing. So, yeah, that's effectively where we're at this point in time.
Yeah, that's great. You've touched on a couple of the limitations that are expected with a single center study that doesn't have a tremendous number of patients, and the idea that we want to expand this beyond just the population that we've studied, both in terms of number, but as well as potentially disease process. Are there any ongoing studies that y'all are either participating in currently or are aware of that are in the field of specific ventilation with MR?
Yeah, I can comment on that. So we do quite a lot of asthma and COPD MR imaging. And what we've been trying to do is to acquire this free breathing data, basically back to back with some of our hyperpolarized xenon studies, so that we can continue to do those comparisons between the modalities. And then we're also acquiring these data sets over time in patients to see how the measurements change over time, also how they change in response to other types of treatments, to try to help us understand the consistency of this measurement across the trajectory of disease, or how it changes, and then also how it changes in response to longer term treatments.
Wonderful. As we're coming towards the close of our conversation, I want to zoom out a bit and ask about what each of y'all are most excited about in the field of either ventilation imaging or MR or both. Sarah, why don't we start with you?
Yeah, sure. So I'm quite excited about the opportunity to, push respirology and the assessment of airflow obstruction beyond the measurement of FEV1. So to, expand our assessment of lung function beyond a single metric, and to look at the lung regionally. I think that will be advantageous in many respects with respect to the management of asthma, perhaps leading to more effective treatments, image guidance of treatments, and just the overall better management of patients with asthma. So we're really trying to tackle here, that angle using various ventilation imaging approaches here at McMaster. So we're not focusing just on proton, but we're continuing to assess, hyperpolarized gas imaging to assess ventilation, also more traditional metrics such as Technegas SPECT imaging. So I just think we need to, push this type of functional imaging, no matter what approach we have at hand, into the clinical space to try to improve the management of asthma.
Great. Thanks, Sarah. And how about you, Dante? What are you most looking forward to in the future?
Oh gosh, I have a few answers for you, but really, generally, I've had a really fantastic opportunity to leverage the knowledge that I've had building these sorts of methods in the past onto now lower field scanners, such as the 0.55 Tesla Remax Siemens scanner that we have here at UCSF. So I'm excited about translating that technology to the current scanners. Obviously there's, one of the limitations of higher field is just the intrinsically low signal intensity and the susceptibility artifacts that you gain. So going to lower fields, and, there's been a huge push in delving into lung imaging, especially at lower fields currently. We're excited to get involved in that. We've been scanning different healthy volunteers and patients on that scanner to just understand what sort of both ventilation and perfusion imaging we can gain from these non-contrast enhanced techniques. Other spaces that I'm really excited about is these sorts of imaging approaches. You're acquiring all this proton-free breathing MR data, and there's so many different methods, as Sarah was describing earlier, to actually quantify ventilation and perfusion from these metrics, such as Fourier decomposition. One that's gained a lot of popularity is called pre-full. So we're exploring evaluation and comparison amongst all these different techniques to maybe identify which ones are best used for which patient group to identify certain regional diseases. So really delving into the imaging physics on that end, or the image processing involved in that. And then lastly, I'm in the Department of Radiation Oncology. So we obviously treat a lot of patients with, let's say, non-small cell lung cancer. And, with the combination of, therapy nowadays, there's definitely an elevated risk of radiation pneumonitis in these patients. So we're really looking at how we can use these imaging approaches to identify not only functional but non-functioning regions of the lungs to better direct our radiation beams to improve overall outcomes in these patients, reduce toxicity. So definitely excited on different fronts.
Oh boy, you both opened up a can of worms of interesting topics to discuss. I feel like we could go for several hours more of discussion, but I do want to bring our conversation now to a close. Before we finish, are there any final thoughts that y'all have, Sarah?
No, I think we, covered a lot of exciting areas, and it was an absolute pleasure to discuss our work with you in this forum. So thank you for that. And it's certainly quite an exciting time for the application of MR to better understand lung function.
Certainly. Thank you, Sarah. And Dante?
Yeah, thank you again for the opportunity to talk today. Obviously, you can tell we're both very interested and excited about this work that we're doing. And we're hoping that this piece of work that we were talking about today, our study, can hopefully add to the growing body of literature to support the use of MR for lung imaging.
For sure. Thanks for that, Dante. Thanks for coming on the podcast. And with that in mind, our listeners out there, I encourage you to check out this paper. It is fascinating. Even if you barely understand ventilation or MR imaging, there's really so much to gain for our listenership and our viewership of the journal. With that in mind, from me and the journal, thank you very much for tuning into the podcast. If you like what you hear from us, please rate, review, and subscribe to us. That's what lets others out there who are interested in this find us. Thank you very much. This is the Radiology Cardiothoracic Imaging Journal, and we will see you next time.